onto the stage here. There we go. Good evening, Lawrence.
Good evening, and thank you very much for that introduction. I don't know if I'm going to say everything about sciatica, but certainly I'll tell you, my aim is really to take away some of the myths and hopefully have you feel optimistic at the end of it that something can usually be done. But I'll also take you some things to look for. So I think we should start really what sciatica is.
I'm going to pass over to you, Lawrence. I will leave you to it.
Oh, thank you. Oh, here I am. Sciatica basically means there's irritation of the sciatic nerve. The sciatic nerve is the largest nerve in the human body, and it comprises of the nerve roots of L4, 5, S1, S2, and S3. Now, you're probably wondering what that is. So I've got a little prop with me, a spine. So when you look at the spine from the side, you've got these little holes. These are what are called the foramina. These are the nerve roots that emanate from there. So right at the base, if I can show you, that's L5, 4, 3, 2. So they all come together. If you can imagine, they all join up to form that big nerve that goes down the back of your leg. So sciatica is really a symptom rather than a specific diagnosis. All it means, for whatever reason, that the sciatic nerve is compromised, either by inflammatory means or by compression. So the next call is to decide, has a person really got sciatica? Because I see many people and they complain of pain going down your leg. Now, is that sciatica? The answer is absolutely not. The incidence of sciatica, if you look in journals, is anything between 2 to 40% in a population. But that might well be because the 40% include those people who say, I've got pain running down my leg. So to be clear about it, sciatica means that there has to be compression and the pain has to be going right down your leg. I get a lot of people who complain of pain in their back, going into their buttock, down to the back of their knee, and that sometimes isn't sciatica. So please bear in mind that if you've got pain running into your buttock and just a little bit into your leg, that might not be compression of the sciatic nerve, but what's called a referred pain. And the other thing to bear in mind is that very often people with hip pain can get sciatica symptoms, pain running down their legs. So you have to differentiate. And the reason you have to differentiate, because obviously the treatment between referred pain from the back or hip pain is completely different. So that's quite important. So I'm always quite careful with people to make sure that they are suffering compression of the sciatic nerve. Then from that, you can form a logical diagnosis and treatment. So what causes sciatica? The things that cause sciatica, as I've said, is usually compression. So things, for example, a prolapsed intervertebral disc. Prolapsed intervertebral disc, if I go back to my prop, these are the discs. Those are the cushiony things that prevent you from, it's like a cushioning, sort of weight-bearing cushion. So you can jump up and down, and these are like shock absorbers, and they absorb the shock. And you've often heard of slip discs. And what happens is that these discs can prolapse. Now, I think on here, yeah, I do have one. So if you see this red bit, that's kind of a prolapsed disc. So it comes out and irritates that nerve, or if it's big enough, it can compress it. And that's when you get that pain. So the mainstay of a pure sciatica, really, you've got pins and needles, you've got numbness, and what I'll come to is sometimes what's called a neurological deficit. You have difficulty moving your foot up and down, or you feel a weakness, your actual back starts to collapse. Some people come into me and they have what's called an antalgic lean, which means a little bit like they're the Hunchback of Notre Dame. They're twisted around. So due to muscle spasm, what your body does, it takes you away from the area of the disc problem. If I can see the mirror image, so I might be like this, And that indicates I've got acute muscle spasm that's taking me away from the area of protrusion, and it's the body is managing it itself. So that's one mainstay of what's causing disc problems, this disc problem, because it compresses. Anything that compresses the, well, I talked about these foramina, these nerve roots, is going to cause difficulty, because it will inflame, it will pinch on that nerve. Nerves are the body's, if you like, electrical wiring, and it's basically giving it a short circuit, and that's why you feel symptoms emanating down your leg. There's another condition, is when you twist and you can get irritation of what are called the facet joints. So the facet joints are adjacent to the disc joints. Those are, if you can see these things here, right on the side. Hope I'm focusing it properly, but these facet joints are very common. So what happens is that you bend over and you twist and it come up, and then a day or two later you start getting pain down your leg. That means the facet joint is irritated, inflamed, and that affects the nerve, which goes again down your leg. So that is a sciatica, as long as you've got those symptoms of pins and needles, numbness, tingling. I hope I'm not getting too technical, and this is what's called neuropathic pain, which means all the nerves are irritated. The sensory nerves, which give you the feeling, the pain, and also the motor nerves, which give you the power. So you have those two big scenarios, which are the most common ways of, narrowing by either the disc or the facet joints, causing inflammatory reaction around there, irritating the nerves. The one that isn't so common, thankfully, are tumours. Any growth, anything like that on there, again, can compress, so you get this sciatic symptoms. It's unusual, thankfully, but you always have to bear in mind people who've had a cancer or anything like that. You can get spread of the cancer around these joints, which can occlude these little holes, which give you that sciatica symptoms. I think that deals with most of them. One thing I was going to say, on the spinal stenosis, it's narrowing. It's very much due to osteoarthritis in these joints. If these joints become arthritic, which is quite common as you get older, they swell up. And again, it causes an obstruction. And that's, again, when you can get that sciatic referral down into your leg. So that sort of dealt with what can cause sciatica. So, anything interfering with the nerves at the base of the spine. But how can you, if you get pain into your buttock or into your leg, you would like to know whether you've got sciatica. So there are two quite easy tests you can do yourself, and I shall demonstrate. One is just, I've got a table here which I can lie on. Hopefully you can see me. But if you've got, for example, right-sided sciatica, you get a friend, or maybe you can do it yourself, to lift it up, lift your leg up. And indeed, you can bring your toes back. If you get pain, which is excruciating going down your leg, you've got sciatica. It may well give you pins and needles and numbers, and that is a sign, because what you're doing is you're putting a stretch on that electrical wiring, a stretch on that sciatic nerve. And if it provokes it, you know fairly well that you've got sciatica. So the other way, if you haven't got a friend that can lift your leg up, or you find it difficult to do yourself, you can do what's called a slump test, which means that you sit down, and if you can see me, you can lift your leg up and you slump. You pull your head down, you can put it down yourself. If that causes pain running into your leg, that you can describe as sciatica. So you can hopefully diagnose that yourself. Now, the thing to watch out for, which I always tell people, or the things that concern me, sciatic pain, which we'll go on to in terms of treatment, can be treated. But there are two conditions one has to look out for. The first one is the most alarming, which I'll talk about, and that's, you may have heard of, it's called cauda syndrome. This is when you have a central prolapse. So this disc, if it squashes right back, and it hits these very small nerve fibers called the cauda equina, which basically innervates the bowels, bladder, and sexual function. So if those get squashed, these are very sensitive nerves. And if there's any symptom of bowel or bladder problems that you find a person can't hold their urine in, that's an emergency, and you can't mess about with it. No, the only treatment for that is surgery, immediate surgery. You have to deal with it within 24 hours to get a good outcome. Otherwise, it can be devastating consequences of loss of function of sometimes legs, bowel, bladder dysfunction. So it's very serious. Now, you'd be pleased to hear, I've been working for 40 years in this field. I've dealt with about 5. Luckily, spotted them all. So they had successful surgical outcomes, and they went back to normal. But that's, that is the most serious condition, and that has to be dealt with. The other one, which is serious, but that can one has time to deal with it, is any what's called neurological deficit, which means that if there's any weakness in the foot, lifting it up or indeed putting it down, that means there's a lot of compression of the nerve. You can allow it to continue for a certain period, but almost certainly it's advisable to get an MRI scan to show the level of compression of the nerve, because they are patients who may need surgery. You've probably heard of foot drop, and that's a classic one where a person, when they walk, the leg flops because they can't lift it up. Dorsiflexion has gone. That's the base of the spine, L5 nerve root down here, the descending nerve root down there. It's got so much compression that you've lost power. And if it's not attended to, or if it doesn't improve after a few months, it's always advisable to get a surgical opinion whether it needs decompression. So I'd always look out for that. And in fact, I had a patient in today who couldn't walk on his toes. I've treated him 3 times, and when he first came, he couldn't sit down because of the pain. Because the moment he sat down, of course, a bit like that test I showed you, you're stretching that nerve, and he was in immediate pain, so he had to stand. So after 2-3 sessions, all his pain's gone, and he can sit again, which is wonderful for him. But I'm still very cautious with him, and I've written him a letter simply because he cannot walk on his toes. He's limping. So that's a big sign that you want to pay attention to. And so with sciatica, although it's a fairly benign condition, there are these deficits, these sort of weakness that we all have to look out for and make sure is assessed properly to avoid any problems in the future. So now we go on to treatment. So I'm going to start really with what you call conservative treatment. I don't know how many of you have sciatica, but maybe we'll find out at the end. But the first treatment people usually go for is seeing their GP, who gives them anti-inflammatories, paracetamol, sometimes a drug which isn't used so much anymore because it wasn't found to be that effective, called gabapentin. These are all drugs that work on these big nerves, helping calm them down, but they have side effects. If you take ibuprofen or things like that, or naproxen, then you have to, help the stomach because it can, cause stomach problems. And actually, from my experience of seeing, basically thousands of patients with this sort of thing, it might take the edge off, and they're not that satisfactory. And of course, they don't do anything for the compression of the nerve. All they're there to do is basically take your mind off the pain. But that obviously can be important because these sciaticas can be devastating in their intensity, stop a person living properly. So I never take it lightly. They are serious problems that get in the way of having a productive or happy life. So after you've had the paracetamol, ibuprofen, etc., you may well be referred to somebody like myself. So what I specialize in, if you like, for treating sciatica, I have two modalities, osteopathy and what I call medical acupuncture, because it's not so traditional. It's based on nerve function. So the osteopathy is it's basically manipulatively based, meaning you're moving the body about or the joints about in certain directions. Now, the first thing to say, anybody with sciatica is in a lot of pain. So very often I have them on my treatment table and I realize I can't really touch them that much because they're too sore. And I certainly don't want to move them, because if you imagine that the base of their spine is already angry, inflamed, if I start moving them about too much, they will want to thump me. It's going to be very irritable in there. So I do use manipulation, but I do it quite softly, just move them back just to get some movement going into the lower spine. The reason for that is when you have a condition like this, the movements of those spinal joints, if I bring my prop around here, become very stiff. It's not much movement because of all this muscle spasm. So when I move a person around, it's done in specific ways. I stretch the joints, and this is thought to have an effect on what are called neuroreceptors, the receptors around the joint and in the muscle, to have a relaxing effect on the muscle. So, so it tends to relax and give a person better functioning. The other thing that manipulation does is takes you moving the joints in there around. You're allowing the nerve to stretch, just a little bit of movement, which stimulates blood flow. And again, we talked about some of the symptoms of sciatica earlier on, like numbness. And it's very much like if you sit awkwardly, very often use my leg's gone to sleep. Basically, you've put one leg over the other, you've compressed the nerve, and there's a lack of blood supply, which causes some of those symptoms. So osteopathy is stretching out that tissue around there. So you're getting an increased blood supply to that area, which helps to restore nerve function. It's what's called neurogliding. You're moving the nerve within the sheath, just helping feed, just helping soothe it, if you like, as a way of explaining it. And there's a lot of evidence that shows that that sort of manipulation does help beyond what's called placebo, that if you leave it alone. The other thing to note is that with osteopathy is that success rate is quite good, as long as we're talking about a straightforward sciatica without that foot drop. That by doing that, after quite a few sessions, the person will recover nerve function, and they'll be in a much better state. However, there's also a limitation, because as I've mentioned, you can't use everything on there straight away, because if you do too much, you can provoke it, and inflammation flares up, and a very often person will tell you, God, that hurt the next day. I've been in agony. I mean, it will calm down again, but you don't obviously want to aggravate a condition that's already bad. So that brings me on to the acupuncture. In fact, the more I use it I've been, as I've said, practice over 40 years. And my mainstay up to 20 years ago was mainly using manipulative treatment. But since I've used acupuncture, I use much more of that for sciatica. The reason is that I don't have to move the person around so much. So there's no potential, or very little potential, of aggravating the condition. So what you're doing, first of all, with needles is that, again, on the spine, these nerves lie very deep. So people often are concerned that I might stick it right in their nerves and they'll leap off the table. But these needles I use needles that don't go to the nerve root, or I miss them, or at least I try to. So when you stick a needle, you'll stick it into the muscle, and you're stimulating small nerves in there, which have a feedback to the brain, and it blocks certain pain receptors. When it blocks certain pain receptors going back to the brain, you get muscle relaxation, a bit like osteopathy, but in a completely different method. So that's why I like to use the two together if I can. The osteopathy gives us some relaxation, so does the acupuncture. And if a person's too, I don't want to move them about at all, the acupuncture does that whole effect for me. So I will stick needles. They're quite, when I say needles, they're nothing like your normal needles you have injections with. These are quite thin needles. In fact, I can show you one just to see how. Here's a spare one. I always have a spare one just in case. So this is, where is it? There we go. So you can see, hope you can sort of see how thin they are. And actually I use, for other people who do acupuncture, I use moderately thick ones. So they're still quite thin. And I'll put it there. But in the back, on the buttock, I use longer needles because it's much fleshier. So because the nerve goes down through the gluteal or your bum area, I need to use needles to go into the muscle, not touching the nerve, but in that area, to elicit a good effect. And very often, I don't know if many of you have had acupuncture, what happens is that I'm stimulating small nerves in the muscle. So very often people say, oh, I've got a bit of a sensation like a dull ache, which always gives me a thrill because you're actually stimulating the area that you need to stimulate. So you're hitting those nerves that I want to hit without causing pain. Because most people, think, oh, acupuncture is going to be terribly painful. It's why would I have a needle stuck in me? Actually, most people report, even people who have been needle phobic, and in the end sort of decided to try. Actually, there's nothing to it. It's not painful. It's a bit of sensation, and it's quite pleasant. And afterwards, a person can feel very relaxed because the other effect acupuncture does, it boosts the production of endorphins around the body. These are the body's natural opiates, a natural morphine-like substance, which have a relaxation and also a pain-killing quality. So there's a lot of data done on acupuncture showing that actually, I was looking at it earlier this afternoon. It was called a Cochrane database, which looks at all papers around the world to get a rough idea of what all the research shows collated. And acupuncture has a 90% success rate. It doesn't mean to say everyone's getting better, but certainly it's more than shows that it's a very potent tool in the treatment of acupuncture. So in combination, using the osteopathy and acupuncture, I think is ideal to curtail the pain and the irritation that sciatica causes. So the other thing I wanted to, I think we've got enough time. Yes, still on time. To talk about is what you can, I'm going to talk about what you can do about it, and then finally I'll talk about what you do when sciatica doesn't respond. So first of all, let's be optimistic. Your sciatica is getting better and you want to do things to help it on its way. What can you do? Well, there are certain exercises you can do. All research shows that the worst thing to do is to go to bed, i.e. not move. So if you have sciatica, keep the movements moderate, but don't be shy of carrying on walking, leading a relatively normal life. Obviously, you'll be curtailed by the pain. So you have to listen to your body. So if you're sitting down like most of us do at a desk all day, get up. I've written about this so many times. Every half hour, get up, walk about, and just get your back moving, because that's what your body needs. We're designed to move, because the good Lord didn't put us down to stare at a screen all day. We're meant to move, run through the savannah or wherever, or the ice flows wherever you are, and be active, which is one of the mainstays of the problems of society today. We've stopped all of that. We just sit and stare. So keep moving. The other thing to do, I can show you a couple of exercises you can do. Just basically, they're very basic, but they do help just stretch, and just do that a few times a day, just to keep the mobility up, but a little bit of movement in the nerve. And the two ones I'm going to show you what's called a knee hug and a leg side bending stretch. What it does, puts a mild stretch in there. There are much more stretches you can do, but I think these are two ones that are quite safe to do back home. And if you're sitting at the desk all day, just do it every few hours. Just get up and do it 10, 12 times. Stop if there's any pain. So the first one I'm going to show you is the knee hugs, which you probably all know. These all come from sort of yoga type exercises, but see me? You're lying on your back, you're bringing your legs up. And it's strange how they call it knee hugs. This might give you a suggestion why. So you can do both legs, or say it was my right side, you could just do the right side. And what I tell patients to do is to basically, what I call tease the pain. So you bring your leg up, and you might feel, oh, I can feel that a bit. And you just put it in and out like that. 10, 15 times. And then you relax. The other thing you can do is what's called a sciatic stretch. This is a bit more profound. I wasn't going to show that initially, but I think we will. You just bring your leg up, you move it in and out like that, because you're stretching right down there, and you're moving it in and out. So you're getting a bit of a stretch in there, right over the nerve. The third one, which is the milder one, is lifting your legs up like this. And basically just that puts a little stretch on your lower back, right in your lumbar spine. And it feels quite pleasant. Just move it in and out like that 10, 15 times. So if you have sciatica, you can certainly use the knee hugs, the side bending stretch, and you could actually try that second stretch I showed you, what's called a piriformis stretch. There is a theory that the piriformis muscle, which I won't go into, might be a cause of sciatica, but all those three exercises are quite helpful just to keep mobility going in the lumbar spine and to stretch the nerve to some extent. So that deals with sort of stretches you can do back home just to try to alleviate it. And what I always say to patients is that once they have a pain, they go hell for leather. They won't have done any exercises, and I say to them, do these exercises, but don't overdo them, because you cannot tell your body, God, I've got sciatica, you're going to get better if you like it or not, and just start moving in and out, 2,000 times for the body to obey you and to say, yes, I'm going to get rid of your sciatica, because the body doesn't work like that. So what you've got to do is just to tease it and not to overdo it. Otherwise, the next day you're going to feel it. You've got to just gradually increase it as your condition improves. Which brings me to the last bit of my talk, and that is what happens if sciatica doesn't improve. Now, I have to openly admit, not does every case I treat improve as I want. Absolutely not. So there are a few people who don't fall within the category of easy improvement. You can give any sciatic person suffering from sciatica, you have to give a few weeks. It's not like you put your back out because the nerve is affected. As I mentioned, there's compression and inflammation. So by definition, all sciatica cases take longer than a straightforward acute back pain, which will resolve, sometimes in one session, 2 sessions, but sciatica is going to take that bit longer because nerve tissue is involved. So I've treated, what I always say to patients is that I give it 5-6 sessions and then I reassess. If a person isn't improving, because I've treated so many of these that I know perfectly well that most will show some benefit within that time. So if they don't, then I start getting a bit concerned we have another chat, because what you want, because all things sciatica, you need to improve quite quickly because the person's in distress. And if there's no improvement, there's no point fooling around, because ultimately you can't see inside. So then we get onto the scanning, MRI scanning, which is what's called magnetic resonance imaging. Some of you may have had it. You go in a tube, and this clever piece of machinery can show you what discs look like. X-rays are useless straight away, because they don't show discs, they don't show nerve, whereas an MRI will show both of these, and you can see how much a nerve is affected. So once you have that, then you can reassess and have another chat and see whether a spinal injection might be helpful. So the reason for a spinal injection, if conservative treatment fails, is because the patient in front of you is in agony, and obviously you don't want them to continue in agony longer than they need to. So a spinal injection is really an injection of steroid around the disc or the facet joint, whichever place is involved, whichever structure is involved in causing the sciatica, and that blob of steroid goes around there and it stops the irritation. Now, the thing is, it's done under ultrasound guidance, but it's done rarely, for the simple reason that most cases do resolve in a period of time. But those cases that don't, that would be their first port of call, to have a steroid injection and see if that alleviated it. Because if it alleviates it, the person go around their normal business, go back to work, doing the normal type of activity, and psychologically they feel better, because the last thing that anyone wants to have is sort of which is commonly associated with depression, anxiety, because people cannot go about their normal business, and it's depressing. So it's very important that they're given opportunity of another form of relief if absolutely necessary. When you look at research, the outcome, both for what I do, manipulative treatment, acupuncture, and steroid injections, after 9 months is exactly the same. So there's no long-term benefit, but absolutely for a short term, to give some relief, it can be of great help. So there's no problem using steroid, apart from if you on the NHS, if you get there in that period. Otherwise, you have to go privately with all the expense there is. So that's the thing that happens. That's the first port of call. And the other advantage is that if you inject the steroid and it gets rid of the pain, and you know that you've injected it around the facet joint, then you know it's just the facet joint causing the problem. If it doesn't get rid of the pain, then you know if surgery is indicated later on, which I'm just going to get to, don't operate. You've got the wrong area. And so the surgery won't be of any benefit whatsoever. Which brings me nicely on to the last topic, surgery. When do you operate? Well, you obviously operate after you've exhausted all other possibilities. Nobody in their right mind, including surgeons, would want to operate unless there was a real need. So we talked earlier on that the red flag of cauda equina, no question, that needs immediate surgery. The neurological deficit, the dropped foot, or you can't walk on your tiptoes, possibly. You can give it time, but possibly they need what's called decompressive surgery. So what that is that surgeons go in, and if it's disc, well, I'll go into spinal stenosis in just a moment. The disc is protruding. Where is it? Oh, there it is. It's protruding. So you go in by the side, or very often from the back, and it's done these days. It's done by keyhole surgery, actually. So there's not much destruction to the muscle tissue. The surgeon goes in and tidies that up, gets rid of that bit, might extrude, take some of the disc away, just to take away that compression of the nerve. So the inflammation dies down. Obviously, you're left with a bit less disc, but you're out of pain. And so the consequences of living without a disc is simply you lose a bit of height, and the spine is slightly aged, which means you're going to be stiffer, You'll still get some backache once in a while, but the mainstay of that terrible pain running down your leg is hopefully gone. So the third thing that is done, and that, I mean, there's quite a few surgical techniques, but there's also spinal fixation or fusion. And that's if the spine is unstable. There is a condition where this joint, L4 or 5, can jut forward. It's called a spondylolisthesis. It's what's called an unstable spine. This juts forward, puts a traction on the nerve. Then you use these small rods to fix the spine so it's solid. And that stops the spine from moving in that area, making it stable. And again, it is used occasionally. So it's highly, I stress, all of you listening, don't be alarmed, because to end up on the surgical table, I mean, I treat, hundreds of people. I mean, I do refer one or two for surgery every year, but it's minor. And of course, I'm dealing with this all the time, so it's not the mainstay. Most of you, I stress, will improve and be completely pain-free, but it's only those, you have to pay attention to those who have got slightly more worrying symptoms. So you can use that surgery to basically remove the bits that are occluding the foramina, these holes. And the same with spinal stenosis. It's much more complicated. These are more in the elderly patients usually, and it's due to osteoarthritis around these joints where they swell up, and you get what are called osteophytes, which are calcified ligaments all around it, and they get in the way of nerve flow. So what happens in there for suitable cases is that some of the bone is actually removed to open up to allow nerve flow. And that can be successful. But all this is a surgical point of view, and I'm not a surgeon. So a surgeon would review the case, look at the MRI scanning, look at EMG, which is see how the electroconductivity is in the muscles, and then treat it surgically if necessary. The last, which is much newer, is rhabdolysis, where needles are stuck in to basically burn off. These needles are done at a very high temperature in and around the nerves to kill off the nerves so they don't transmit impulses. Now, I'm not a huge fan of it, and it is going slightly out of fashion for the simple reason it can be helpful, but those nerves grow back because they're sensory nerves. They're not the big motor nerves, which don't grow back, unfortunately. Once they're gone, like in a spinal injury, they don't grow back. But these sensory nerves, you're jinxed. And so when I see these patients, they have this procedure, and they're fine for 2-3 months, and then the pain comes back. But it's a technique that can be used, particularly if a person's in terrible pain, because they're in so much pain, they'll have anything done. So I think that more or less concludes my talk on sciatica. And so if you have any questions, or you might even have it and you want to speak about it, I'd be very happy to take your questions. If you want to know more or any exercises, just email me, and I'm happy to send you links of the different exercises, YouTube exercises I've got on my website. Thank you.
Thanks, Lawrence. Really, really useful. So I've got a few questions actually, if we don't get any more by the end, but we've got a question here from Colin, it's a really good question. Would like to know a bit about mattresses and sciatica. So is there a correct mattress for sciatica? Does it depend on your particular case, and how would someone know?
Well, that's a very good question. I have a lot of mattress talk and pillow talk. I mean, the problem with mattresses is completely individual. So people often ask me, what mattress should I use? And I always try to change the topic because there is no one size that fits all. But saying all that, for any mattress, if you look at the literature, by far and the best for any back pain is what's called a firm mattress. Do you have to go out and buy an expensive tempura mattress, and all the, you can pay thousands for mattresses? There's not much evidence that it helps. So and I'll say the same for pillows. The main way to do it is to go to a shop and look for a mattress, lie on it, say, this feels fairly comfortable, and then make sure that the shop selling it is happy to take it back after 6 weeks if you don't like it. So basically, you're trying out the mattress, seeing if it suits you, because everyone's got a different anatomy, you've got different muscle mass, so it's impossible to give a direct advice to say this is the mattress to get if you've got sciatica or indeed back pain. But basically, a firm mattress is better than a soft one. And you don't want spring mattresses, because springs go and you're lying all over the place, which might not be so comfortable.
Is it possible for you to give someone a kind of indication based on their particular problem? Like, I've been told I sleep on my side, so I need a slightly softer mattress so my hip can go into the mattress and so on. Is it possible to give someone some guidance before they get to the mattress shop?
Well, the thing with that, I mean, that's a good point. You see, if you have a soft mattress and you're lying on your side, if you sink in, you know what I was talking about, people with sciatica having what's called an antalgic lean. In other words, they're twisted. So if you lie on a mattress and it's soft, it's going to twist you more, so potentially aggravate you more. The one thing I will say about people with sciatica, 2 ways to sleep. You want to reduce the traction on your lumbar spine. So the obvious way to go about it is to put something either under your knees. So if you lie supine, lying on your back, you put, I've got something here, like a couple of pillows under your knees, because that will raise your knees and immediately there's less traction on the back. The other thing I always say to people is for them to lie on their side, because the thing with sleep, very few people stay in the same position. They move about. So when they twist, they say, I got comfortable, then I fell asleep, and I wanted to move, and the pain wakes them up. And the main thing with sciatica, again, is that you need your sleep, because very often people don't sleep, and they become irritable, can't function properly. So a much easier way is to have your firmish mattress, lie on your side, put a pillow between your knees, because that basically stops the leg over-rotating. When it over-rotates, it brings the spine with it, so you get more of a twist, which puts more traction, which irritates the nerves.
Brilliant. Okay, some good advice. Thank you. Let's move on. So I've got a question from Kathy.
Yeah.
I've had this a little bit the same as well, because I've sort of had sciatic pain for a few days, actually. I was quite lucky, and it's gone away, and it's left me with this lingering feeling. What happens if it comes back? Should I be doing something about it, even though I feel okay now? Does it matter? Will it get worse? What's your advice to someone with occasional sciatic pain?
Oh, well, hello, Kathy. Yes, I mean, if it's coming and going, it's actually a good sign, because it shows there's not too much compression. And it goes to the earlier part of my talk. If it is, we've got to first establish whether it is first the compression on the nerve. If it's coming and going, it's less likely. So the prognosis already is quite good. And it's basically what a patient can tolerate. So, for example, if you're going around and some days it's better, some days it's worse, some people may decide, well, I think I'll leave it, which is perfectly acceptable. But once it starts staying and it becomes a sort of feature of your life, I think it needs intervention, if you have problems with it. And which brings me on that when a person comes and goes, very often people can wake up in the morning and say, oh, it feels relatively okay. Reason being is that you haven't been moving. Once you're upright, we have this stuff called gravity, which keeps us grounded to the planet. But one of the other effects, it puts compression on the facet joints and on the discs. So very often a person say, well, I started off okay, and as I started walking, this pain started to come, and it got worse as the day goes on. Similar for sitting. When you sit down for prolonged periods, and which I keep on banging on about it, it markedly increases what's called your intradiscal pressure. So your discs, the pressure around there. And so if you're increases, so if you have a disc prolapse or irritation, obviously sitting down is probably one of the worst things you can do for prolonged periods. I mean, we all need to sit, granted, but that's why I'm saying it's very important to take breaks so that the forces are precipitated, because we're all a product of gravity. You know, it's what makes us smaller as we get older. Even I'm shrinking. So be aware that if it eases once in a while, you take a view on it, and if it's getting a bit much for you, then give me a call and we do something about it. But I mean, I tend to leave it to patients, because they know what they can tolerate. You know, if they can live with it, it's totally up to them. It doesn't sound alarming, so it's really a convenience. If you want to be rid of the pain, then get somebody to look at it and have it treated. As I said, I'm not sure it is sciatica if it's coming and going, what I was talking about earlier on.
I think maybe a bit of advice there as well that's pertinent to all of us is, if the pain goes away, to keep up the good habits, make sure you do move and you do stretch. And then, as you say, if it's becoming more regular, then go and see someone.
Yeah, anything permanent starts raising alarm bells. So if it's coming and going, it's inconvenient and it's unpleasant, and you may want to do something about it, but I wouldn't lose sleep over it. Well, you may lose sleep because it might be painful at night. So you have to take a view, is this bad enough to, you know, that you want to treat it? But what certainly needs looking at, if you get any weakness in your, you know, those are the alarm bells for me. Any neurological deficit, which we talked about, any, you know, bowel bladder function, that needs to be seen. You can't mess about with those. But all the others, it's up to it's up to your tolerance of whether you want to go on living with that, you know, off-on pain. I can't answer that. That's a patient's prerogative to decide, well, I've had enough of this. I want attention taken to this problem.
Brilliant. Thank you, Lawrence. Well, if anyone else has any more questions, do drop them in the chat, or do email them to me if you'd rather ask them anonymously. My email is at the bottom there. I've actually got a few questions in the meantime, if no one else drops anything else in. So the first thing, we've been sort of going through a lot of sciatica groups and Facebook groups and so on in preparation for tonight. And something that strikes me is a lot of people are in like a hell of a lot of pain. Like they're not going to work anymore, they're not moving, and so on, which must become extremely scary very quickly.
Yeah.
My question would be, how do you encourage people to stay positive, and what should they do when the pain is such that it's not just affecting your life, but really preventing all your day-to-day activities?
Well, that's why a lot of people come to me for sciatica. So the first thing is, I mean, I think of, you know, because very often people see me at, you know, they've been to their physio, through their GP, they've done everything, and, you know, they've been off work for a period of time. But I suppose the way I work really is I like to see results fairly quickly, so I don't mess about. So, you know, I know fairly quickly if a person is responding. So if they've got what we've been talking about, a sciatica with the pins and needles going down their leg, you know, I'm quite blunt. You know, we've got to see improvement fairly quickly to warrant the treatment, because I'm being sought after to rid them of the pain. So my duty, if you like, is to make sure to give adequate improvement quickly. So, and sometimes after the first session, there might be some relief. If you do that, a person immediately feels more positive, something can be done. So in that sense, you know, I don't really, I mean, it's not that, if you give encouragement that there's a good chance they will improve, but without being, you know, unrealistic, because I'm always realistic. You know, I mean, I do say straight away, this case is a difficult one, and we'll see if it improves. So I think if you're, you know, honest and give a frank opinion, then a person says, well, this person might be able of help in a realistic way, because there's so many people say, oh, you've got sciatica, no problem. You know, if you know, cross my palms with silver, you know, after 10 sessions, you'll be cured. I never say that, because I'm always cautious. So I have to see improvement to warrant the treatment. Mm-hmm. So I think on that basis, I really haven't, you know, most people I see, if they do get better, well, that's enough encouragement. So I don't have to do anything else.
Okay. But on a general day-to-day basis, I mean, maybe someone could, I think the important thing is seek out treatment, is it? Try and keep moving the best you can, seek out treatment, and believe that the treatment that will help you is out there.
Yes, I think that the thing is that don't be bamboozled by, that medication is going to cure you. It's not. And whatever happens, keep active and wait. Because if you don't want to have any treatment with sciatica, that's not a problem. You're not going to die of it, as I keep on saying to people. It's a major inconvenience. I mean, the case you mentioned where a person's screaming with pain, they need intervention. But I think the last person who asked intermittent pain, it's a choice. Yeah, so it's not, you're not going to die of it. It's an inconvenience, and then you decide whether you want something done. So you just have to look. You just have to do what is right for you. Not be. The drugs are going to be of maybe a little benefit, not major benefit. If you leave it alone, it's a bit like back pain. Very often, a person will call me, "I'm in terrible pain," and they've had it for 2 days. I say, well, come if you want to, I can speed it up. But if you leave it alone for a week, much of it will go. Sciatica, if you look in the textbooks, they often say, it will go after 8 weeks. Yes, some cases will, some cases won't. But it's whether you want to keep in that 8 weeks, be in agony, or whether you want somebody to alleviate it within that time and to keep a watch on it. Because sciatica isn't like putting your back out. It's a stage on. So you do have to be a bit more wary and careful with it. That answers your question.
Yes.
Sure.
So do feel free to drop us more questions. Another one that's crossing my mind, again, based on a lot of the conversations I've seen in sciatica groups, it's people maybe, as you said, they've gone to a physio, they've gone to their GP, they've tried this, they've tried that.
Yeah.
Then there's you saying I can treat it, an acupuncturist saying I can treat it, someone else saying I can treat it. How does the patient who's not medical know which therapy should I try next? Should I do this? Should I keep throwing money at all different people? How do they know where to go next?
Well, that's a complicated, difficult to answer. I mean, most people, with sciatica, I say number one, I think I started saying that manipulation was how I started. Then I used acupuncture. So if a person's in a lot of pain, I would seek much more the acupuncture side because they're less likely to have side effects. I would always advocate somebody who's been well trained, of course, because there's a lot of people who are not so well trained, shall we say. And then you can get, well, it's not going to be severe, but they might not have the response that they need, and say, well, I've seen a lot of people who've had acupuncture and they come to me, so I've had acupuncture. I say, fine. Can I have one more go at it? Because you don't know what they've done, because a lot of people will stick it in the skin, and to have any effect, you've got to get it into the muscle. And so you've got to be au fait with doing it in inverted commas properly. Otherwise, it will have no effect. You're not going to damage a person. But so I think for all these things, if you're using acupuncture, you've got to make sure the person's qualified properly. In osteopathy, you can't call yourself an osteopath anyway, unless you actually are. Otherwise, because it's on the state register. So I think these days you just have to word of mouth or know somebody, or you just
look for the qualifications, the experience, and
you might find somebody with experience who doesn't suit. I'm not saying that I'm the end all and be all of it, but you've just got to find somebody that works for you. And I can't tell you everybody who it is, and that's done by chatting to people, and sometimes you just have to take a leap in the dark and say, well, this one seems to have been doing it for some time. Not too many have ended up with adverse effects, and go ahead with it.
Okay. So one last question I think I'd like to know, maybe some other people watching would like to know, is just a bit more about acupuncture and the mechanism of how that works, because you said you don't stick needles into the nerves.
No.
Yet it's a nerve issue. So my understanding of Western acupuncture is you stick the needle deep into the muscle, and that provokes a healing response. You get more blood, more white blood cells, and so on. How does that help with what's essentially a nerve problem?
Right. Well, this is a major topic. That's good for another webinar, but I'll try to be brief about it. I mean, in a nutshell, acupuncture is access to the nervous system. That's it. So what you're doing is stimulating nerves. Now, a lot of people read about, acupuncture magazines. It's all about meridians, chi, etc. I mean, I trained in acupuncture, God, dare I say, 35 years ago. I mean, I know I look too young, but there you go. So I trained in, both in England, and I worked at a hospital in China using acupuncture. And that was very traditional. You felt the pulse, the tongue. You didn't feel the tongue, sorry, you looked at the tongue rather. So, and it's done on the traditional basis of meridians, which probably people have all read about. So meridians are these channels flowing up and down the body, which purport is the flow of chi. I mean, 20 years ago, I went into medical acupuncture because in a way it made more sense, and I didn't have to worry about all these meridian configurations, because basically meridians follow nerve pathways. The ancients were quite clever. They didn't have the language to talk about nerves, so they talked about chi, which is broadly, if you want to translate it, is a conglomeration of both nerve conduction and blood flow. So because you asked me what it does, and basically you're sticking a needle in. You've got a noxious stimulus. You've probably not purposefully, but accidentally stuck a needle in your hand or your thumb sometime. And what do you see? You see what's called the wheel response. It's an inflammatory response. You get redness around the needle. You get this flush of blood to it. So that's a traumatic reaction to inverted commas, an injury. We're using much smaller needles, of course. So you get that, first of all, around the needle, a specific reaction around the needle that brings blood to that area. Secondary effect is that you're stimulating what's called, is going to get very technical, so you'll have to excuse me, myelinated C fibers. These are sort of twitch fibers running in the muscle. And what it's thought it does, I mean, there's been a lot of studies done trying to elicit the exact mechanism of how acupuncture works, but you're stimulating nerves. Or when you touch yourself or hit yourself with a hammer, nerve flow goes back through the spine to your brain, and that's where you perceive pain. So you're getting pain from sciatica, and that's your, ooh, it hurts, but you're actually feeling it in a way in your head. It goes to the brain, which perceives the pain. So I'm sticking needles in your back, and I'm stimulating different nerve fibers in there. Those messages go up via the spinal cord to the brain. And so it's getting very technical, so stop me anytime. There's this gate control theory of pain, and it works by competitive inhibition. So what happens is that I'm stimulating these small nerves, which don't cause pain. They might cause an achiness. They use the same channel to go up through the spine to the brain. So it works by competitively. There's not enough room for the painful stimulus to go up, so it inhibits it. So that's why you get that reflex inhibition of pain. So afterwards, I can often feel straight after a session, I feel the muscle and it's totally relaxed. And that may not be permanent, but the relaxation is there. So I know I'm on the area and the person will feel better. They'll need it repeated because, like with all things, like medication, if you've got a headache, you take one paracetamol, your headache goes. But if you don't take another one, it's no good saying, oh, my headache's come back. Well, you didn't take your second dose. It's a bit like treatment. It's cumulative. So once you've done a few, it accumulates. So you get that relaxation. And when you get that relaxation, it's like the whole body is homeostatic. It settles back into its old rhythm, which is the pain-free condition. In fact, talking medically, no matter what medicine you use, and I say this to everybody, you're not actually curing it in a way. What you're doing is you're helping a person alleviate all the pain and the irritation around there. I think in a way that works with the body. So a person's out of pain and the body readjusts itself. No matter what you do, whether it's anti-inflammatory, surgery, none of it is curative. I'm not suddenly getting rid of the disc prolapse. I'm alleviating it because the body eventually will absorb the disc. And this is the whole reason the person doesn't need immediate surgery because the disc will dehydrate with time and not be the bother that it is. So that's why it's important to try to stave surgery, because the body, in a way, will repair itself with time. And my job is to get a person back to normal functioning without pain, even though if you MRI the person afterwards, they might be the same. With time, that will all decrease. But the main thing is their normal functioning. And because I've been using a little bit of manipulation, I've facilitated movement of the spine so a person can move about a lot easier and out of pain. Is the important thing, because pain is what brings anybody to have treatment. People on the whole don't like pain.
That's why we consult any medical practitioner in the first place, isn't it?
Yeah.
Well, Lawrence, thank you very much. We've reached the end because we're now at an hour, so we've done our scheduled hour here. Thank you very much. I hope it's been very useful for people. I've just dropped into the chat Lawrence's email. If you'd like to ask Lawrence any further questions, I'm sure he'd be happy to help. So it's info@holveyosteopaths.co.uk, and Lawrence's website address is there as well. If you're in London and you'd like to see Lawrence for treatment, then you can contact him through the website. If you have any other questions or you'd like to just give Lawrence a call, then by all means go ahead, I'm sure. If you have any feedback on the webinar or you'd like to suggest something we might do in future, my email is there, chris@marketyourcliniconline.com. So please don't hesitate to contact either of us. So thank you very much again, Lawrence. I hope that's been useful for the people watching. And so we'll come to an end there.
Okay, well, thank you very much for everyone for listening. I hope I haven't spoken too much. I got quite carried away on some of those questions.
It's good that you do, I think. Well, thank you everyone who watched, and we'll leave it there. Enjoy the rest of your day or evening, depending on where you are. And thank you again, Lawrence.
Thank you.